All right. Thank you for being here today, taking the time to watch this. This presentation is brought to you by Fit. If you haven't got an opportunity to check them out, they're doing some really cool things in the sport performance realm. I've had an opportunity to demo Fit a couple times now, and really blown away by what they're doing there. I think it's a pretty incredible product. So thank you to them for give me this opportunity to present today. My name is Connor Shep. I am the owner of Rebuild Performance and Rehab, located in Pittsburgh, Pennsylvania. We are a performance and end stage rehab business located in the northeastern part of the city. Today, I'll be presenting to you on the Rebuild, a system for groin rehab. So, groin injuries are complex and multifactorial. It reminds me of this picture over here on the right. If you've ever worked with a groin injury in the past, you can understand that they are extremely tricky. And oftentimes, there's a lot of multiple variables going on that could be causing these symptoms, right? We're talking about a structure that's very close in proximity, lots of things layered over one another, making it really challenging to diagnose what exactly is going on. One study showed that 19 out of 21 patients suffering from groin injuries showed multiple signs of multiple diagnosis following imaging. I can speak to my own experience. Last year, I was working with a soccer player, a just showed up on campus, no previous history of groin issues, started to have some pain early on, got to the point to where we went in, decided to get some imaging done, and what we found was a small hernia on the side of you know where the symptoms were at, right on the right side. What we didn't expect to see was an even larger hernia on the opposite side, up to this point, that had been completely asymptomatic. So, just all that to say is that oftentimes it's important that, whenever you're working with a groins, that we want to avoid maybe pigeonholing what may be causing these issues and looking at it from more of a holistic point of view, right? So, what do we know about groin injuries? Okay, I think anytime you're working with a groin, it's important that you review some of these anatomical regions and what maybe some of the facts are about them. So, in terms of mechanisms, 48% of groin injuries are non contact, 13% are contact, and then 20% are just from gradual overuse. Primarily seen during kicking, cutting, lunging, or skating. Groin injuries make up as much of 30% of total injuries in certain sports. Athletes at the highest risk are field court and skating athletes. Males are at a 2.5 times greater risk for groin injuries than females. Eastern Europeans, or those from Eastern European descent, are at a considerably higher risk. And then adolescents, so ages 10 to 19. All right. Groin injuries can come in a large factor or a large scope of diagnosis. So, in terms of frequency of injuries, adductor strains are going to be your most common at 60%, inguinal injuries 15%, hip related groin pain at 15%, iliopsoas 7%, and then pubic 7% as well. So, when it comes to actually grading groin injuries and just soft tissue injuries in general, there's a lot of different classifications out there. I think the one that does the best job specifically for groins and hamstring and quad injuries is the British Athletics Muscle Injury Classification. It came out, I think, in 2022, and it does a really good job of describing actually what's happening at the anatomical site from a structure standpoint. So we can look at it from grades 0 through 4. Okay, grade 0 being no signs of structural damage. Uh, these are 5 to 10% of the time in groin injuries, generally leaving athletes out for 1 to 7 days. Grade 1 being minor structural damage. These are 40 to 50% of all groin injuries, leaving athletes out on average for 1 to 3 weeks. Grade 2 would be moderate at 30 to 40% of groin injuries, 3 to 6 weeks layoff. Grade 3 would be a major groin injury, 10 to 15% of the time for 6 to 12 weeks. And then grade 4 being a complete tear. These are just 5% of groin injuries with a 3 to 6 month layoff. Okay. And then we can look at it a step further than 0 through 4 at grade A, B, and C as well. And this is telling us what structures are actually being damaged. So grade A would be myofascial, meaning this is actually happening at the fascia. These are the most common at 50 to 60% of groin injuries, leaving athletes out generally for 1 to 3 weeks. Grade B would be musculotendinous, meaning it's actually happening at the musculotendinous junction. This makes up 30 to 40% of groin injuries. This leaves athletes out on average for 3 to 8 weeks. And then grade C, being the most generally severe, would be tendinous, meaning it's actually happening at the tendon for 10 to 20% of injury cases, leaving athletes out for 6 to 12 plus weeks. So, anytime I talk about rehab, I think about this injury paradigm. So, if you're looking at my mouse here, you can see that we have this baseline level of preparedness, right? And all preparedness is just a certain level of physical ability. Injury occurs, and that level of physical preparedness drops down, right? Significantly. Make sense? Well, in a traditional model, what you generally see, especially in the team setting, is lots of rest, passive treatment, and low intensity loading. And then, based off of predetermined timelines in historical literature, uh, we see this very sharp spike in sport specific loading, bringing the athlete back uh, at a lower state of preparedness than their baseline and before they got injured, right? And inherently, this doesn't make a lot of sense because if they got injured at a certain level of physical literacy and now it's lower, it only sets them up for more injury and even greater injuries later on, right? And what I'm going to be talking to you about today, and where I think our field needs to start moving towards, and it has, is more of a tactical model, right? That once the injury occurs, we emphasize, this incremental process to work the athlete back to a heightened state of preparedness, emphasizing early optimal loading, a progressive criterion based protocol, and then a collaborative return to sport protocol as well, right? Again, putting the athlete in a position to be successful once they actually get back to their sport, hopefully sooner and in a better state of physical preparedness. So I'm not going to spend a whole lot of time on these, just because that kind of outweighs the scope of this presentation. But anytime I talk about training or rehab, I think it's important that we touch on these principles. Right? I talk to way too many practitioners and see way too many rehab cases not to emphasize these. Right. So just to quickly review, what those are and what they mean to me. I have these 12 principles, and I'll kind of hit on them more as we go throughout this presentation. But one being just master movement. All right, movement is the most important quality, and it's the one that all other qualities are expressed. Progressive overload, just gradually increasing the intensity, density, or frequency or complexity of the movement. Specificity is just our said principle. Vertical integration means we're training all qualities at once, just to varying degrees of intensity, density, and volume. All injuries are brain injuries, meaning that anytime there's an injury to the body, the brain is going to fit into that equation and how we go about rehabbing that process. Assess, don't guess, right? What's tracked is recorded, or what's tracked is improved. Reverse engineer, just meaning we identify the sport, their position, the athlete, and their injury, and start from back, or start where they're at now, where they need to get to, and reverse engineer the process. Training continuum. All training and rehab lives on a continuum of general to specific, simple to complex, isolated to integrated, and so on and so forth. Periodization just means that we have a plan. Plan B means that we're ready for any scenario on any given day. Keep the main thing, right? It's easy to get bogged down in the process of trying to do too many things at once. Let's make sure that we're keeping the main thing. And then ultimately just keep it simple, right? That doesn't mean that it's not complex or that we're not accounting for multiple factors. But at the end of the day, let's keep the main thing, and keep it clear. All right. So, linear model. So, the nice thing about working in rehab is that it definitely lends itself to linear concepts, right? And I'll talk about that, kind of what that process looks like later on. But generally, for rehab, it's just going to start either in a short term progression or a long term progression, right? And in my system, long term progression would just mean requiring surgical intervention and significant time off, talking about days or I'm sorry, months or years, versus short term rehab, which is the case study that I'll be kind of walking us through today, which would be days or weeks, right? And the reason that these linear models lend itself to the rehab setting is that these qualities build on each other, right? So in team training, in the team environment, we have to account for a lot of different other stressors and making sure that we're maintaining all of these qualities in comparison to rehab, where we have to lay these foundational qualities before we can necessarily move on to developing these other qualities, right? And the qualities that we train later on down the road are only going to be enhanced by the qualities that we emphasize right now, right? And so again, that doesn't necessarily mean that we're not working on all qualities at once, but it is important that we lay a foundation, right, at the bottom of the pyramid to allow for a higher peak for when we return. So again, what does that look like? Short-term rehab, days or weeks, a little bit more of maybe a conservative approach, generally less major injury. We're looking at a plan B approach where we're just trying to uh, mitigate the detraining effects and support the healing process. We're removing any contradicting stressors and more of a aggressive reacclimation back into the training environment to avoid any necessary or unnecessary detraining. Long-term rehab, where we're looking at months or years, a little bit more of an invasive approach, generally requiring a surgical intervention. This is where athletes are going to be fully modified from their team, and a very slow and progressive reacclimation back into the training environment. And what I really want you to take away from this graph or this graphic up here at the top is just kind of this linear process of restoration, preparation, and realization. And you can just see that it's a very linear approach, and it covers all bases of kind of this linear rehab process. And I think it's important that when we're creating these systems that we create them in a way that we're able to scale them out to short or long-term scenarios. Okay, and the next thing I want to point at is the dichotomy between the isolated rehab and the return to run. That's kind of the way that I'll break up this presentation today, um, just to kind of give you an idea of how these things fit together and how we're going to go about organizing this rehab throughout this process. So, considerations for strength. All right, consider all potential limiting factors of the lumbopelvic region and how they may impact each other. All right, it's not necessarily one area that we're only focused on working on. We're focusing on how each of these areas individually, and then how each of these areas influence each other. Right. So one example specifically in groin-related injuries that I think is very common is when the adductors are stronger than the lower abdomen, which can create a pull on the pelvis forward, which creates shearing forces across the pelvis. Okay. So making sure that there's a level of asymmetry across the lower abdomen and the adductors. We can also look at intralimb deficits, meaning deficits within the same limb, which have shown to be a major risk factor. So, for example, adduction and abduction ratios of 80 to 120% are considered appropriate, right? Anything outside of this being high risk. This can be done through, you know, Kangatech testing involved, force frame testing, manual muscle testing that you see down there at the bottom right. But one thing that I found to be very correlated to groin related injuries. We can also look at inner limb deficits, meaning the deficits between the left and the right side. Um, while less of a risk factor in comparison to the intralimb deficits, it's also extremely important. I think the groin is very interwoven and connected structure, and um, the strength ratios between the left and the right side, I think, can play a very important role with each other. And generally, what we'll look at is anything greater than 15% is going to be a red flag. 10 to 15 is going to be what I would determine a moderate flag. And then 0 to 10 being well within normal ranges. Other strength considerations for groin rehab, isometrics are going to be a very integral part of the process, and they're very popular in the groin rehab, I guess, community, you would say, or practice. Um, and for good reason, right? The groin is filled with copious amounts of connective tissue, which we know responds well to an isometric stimulus. But it is also important that we understand that there are limitations to isometric training. The largest one, in my opinion, just being the lack of contractile specificity of dynamic movement. And then two, just understanding that isometric strength is only specific to the region that it's trained in. So if you're training strength in a certain region, you're only getting neural benefits outside of about 10 to 5% in any given direction of that range is trained in. So it's important that we're training all contraction types, one specifically being eccentric loading. Uh, I think a lot of the reasons, or part of the reason that a lot of these groin injuries occur in the first place, are because of these overload and eccentrics. And what we see after injury uh, are large deficits in these eccentric capabilities of strength and rate of force development, making it very important that we go back and readdress these eccentric qualities later on in the process. Core considerations. So the muscles that make up the pillar are going to greatly impact the pelvis and its function. The lower abs need to be able to posteriorly tilt the pelvis, and the obliques need to be able to support the pelvis in the frontal plane. So it's just important that you address all functions of the core, bracing, rotation, flexion, extension, and how those things operate. And if there's any limiting factors in how the core is functioning. Mobility considerations. I love this quote from Dan Paff: "A bad pulley will fray even the strongest rope." Uh, so just highlighting the point of, I think, particularly at the hips and the hip joint, that if you have dysfunction there, it's very easy for that dysfunction to cause damage to the surrounding tissues. So there's a very strong correlation between poor hip mobility, particularly hip internal rotation and groin injuries. So as you can see, the video is up on the top right. That's just me taking an athlete through a hip flexed internal external rotation. This is a test I'll do with all my athletes, but specifically those working back from groin related injuries. So what I'm looking for there is greater than or equal to 35 degrees of hip internal rotation, uh, 40 degrees greater than or equal to of hip external rotation, and then just a total arc of combining those two numbers of greater than or equal to 75 degrees. And then from there, we're also looking at less than or equal to 10% asymmetries from the left and right side. Other mobility tests that we'll look at is the Table Thomas test. Uh, if we're looking over here at this picture on the right, looking at the psoas, okay, is there any separation between the hamstring and the table? Looking at the rec fem, when I press on the leg from the front, is there any sort of excessive kickback from the quad? And then from an anterior view, looking at the foot, is it turned out at all? Trying to assess the TFL. All right. Other mobility considerations for groin is just to be mindful of rushing back into aggressively stretching those areas. The groin is a very sensitive area, and by rushing back to create torque on those tissues can exacerbate the pain if not done appropriately. So just be conscious of that. Also understand that certain athletes are going to suffer from anatomical limitations that prevent them from maybe reaching certain uh, mobility patterns or mobility restrictions. So, one being the most common is just athletes that present with some sort of FAI, which I'll hit on a little bit later on. But for this, some of the things that I've had success with is just taking the hip through internal and external rotation in more of an extended position, as well as putting them in some flexion. Um, and getting them to posteriorly and anteriorly shift the head of the femur, which you can see over here on the top right video. And then for me, just a linear progression of soft tissue prep to passive mobility to active mobility to end range strengthening. So anytime we're talking about hips or groin related pain, I think it's very important that we account for anatomical or structural considerations, right? The one being very common that I've found, especially in field and court sport athletes, is FAI or femoral acetabular impingement. All that is just a bony buildup upon either the uh, head of the femur, which would be a cam lesion, or a buildup upon the rim of the acetabulum, being a pincer. Okay, cam being the most common at 70%, pincer being next at 30%, and about 25% of cases are going to have both. Signs of FAI: restricted hip internal rotation, anterior pain on the front side of the hip, troubles with hip flexion, or any sort of radiating pain from the hip down into the groin. Okay. One of the ways that I'll go about assessing that, if we were watching this video here, is just a hip scour test. So all I'm doing is taking the athlete through some rotation and hip internal rotation, where I'm just driving the head of the femur into the acetabulum and just trying to identify, okay, am I feeling anything catch, or is this causing any sort of excessive pain? And I've had a lot of success identifying FAI cases early on in the screening process, before we get to any issues later on down the road with these. Other structure considerations would be the pubic symphysis, the SI joint, and hip alignment. While a lot of certain structures are predetermined from genetics, we can influence some of these positions with manual interventions. I think it's important that you understand your scope of practice and kind of how you fit within that team. But if you are comfortable performing some of these things, these are some things that I've had success with. Um, One, just identifying the hip structure of where the ASIS sits by placing your thumbs across them. The inchworm drill, where you're just having the athlete as slowly as possible laterally hip hike. So it would be elevate and depress the hips, moving through a full range of motion. And then, as well as performing an adduction and abduction reset, which you can see with these videos here on the right side of the screen. Motor control considerations. So the inability to control the pelvis is often the culprit behind increased stress across the lumbopelvic region. Rehab is an opportunity to refine and slow things down and reteach some of these fine motor skills in the team environment that we otherwise may not have the opportunity to do. So just teaching the pelvis to move in all ranges and all functions. I think taking the time to do these things in the rehab process sets us up for a lot of success later on down the road. And then movement strategy considerations, and in my experience, probably the most important one. Athletes that present with consistent injury patterns that traditional rehab doesn't seem to fix. Generally, I see one of a couple things. One, it's either poor management. Two, there's a structural limitation. Or three, and very common that I see is just a poor movement strategy. All right, so I'm a really strong believer that movement is the one qualities at which all other qualities are expressed. So I think it's very important that we have a technical model to work from and evaluate these athletes and how they move, so we can start to peel back some of these layers of what may be causing these injuries to begin with. One study that I want to point you to is Linking Acceleration Strategies and Injury Sites by James Wild, 22. In this study, they broke up a series of, I believe, lacrosse athletes, and they just had them perform linear accelerations. And what they broke them up into was this quadrant of high stride length versus low stride length, and then short ground contact time and long ground contact time, right? And from this quadrant, they created these archetypes of bounders, striders, bouncers, and spinners. And what they found was, and what I think is fascinating and something that I think we need more research in this field on, is each of these archetypes gravitated towards certain injuries uh, and certain frequencies of injuries. And the ones that I want to point you to specifically are these bouncers and these spinners. And the spinners specifically looking at 43% of their injuries came from hip flexor and adductor related injuries. And then the bouncers, 33% hip flexor and adductor related injuries, right? And if we look at their strategy, we see that they have a very low stride length. And specifically the spinners spending a lot of time on the ground. And so if you just think about it like tires spinning in the mud, these are athletes that are trying to win with a lot of frequency and a lot of time spent on the ground, and trying to win, you know, uh, ripping that hip up and through, right? Which can, we know can inherently create a lot of stress at the hip and the groin. So just something to keep in mind kind of as we go throughout this process. I think when you're working with athletes, these archetypes aren't necessarily bad. I think they can all actually be very effective and very fast. My question would just be, are they efficient? And so for me, when I'm working with an athlete that's really far away from, the norm, or really, deep into one of these archetypes, my thought process is how can I move them towards more of a neutral pattern? And this isn't just with acceleration, but all movement in general. And the way that I go about that is kind of the reverse engineering some of these high intensity actions. Okay, so this is something that I took from Alan Murdoch, and I'm not going to go too deep into him, but this is just the way that I go about rehabbing uh, you know, the return to play process. Is just looking at these high intensity actions of acceleration, max velocity, lateral gait, and deceleration. And so for me, when I'm working with an athlete out on the field, I look at their postures. Okay, can they hit certain positions? Their patterns. So how do they transition from these positions? and then the power or the physical qualities that underpin uh, these movements. Okay. And then from there, I have a blueprint of trying to identify, like, okay, do they meet these criterias? And if not, what is what may be causing some of these issues? All right. So now, actually getting into the rehab process. All right, we create a roadmap. All right, so where do we go from here? Where were we? Where are we now? And where do we need to go? All right, focus on what you can do. All right, we're going to develop a criterion based system as opposed to timeline, filled with objectives and methods. We're going to have isolated rehab, focusing on passive treatments, mobility, and strengthening. And then our return to run, focusing on just that, our running, our sprinting, our change of direction, and conditioning. And then each phase will also have exit criteria made up of subjective and objective tests that show the athlete is prepared to progress forward. All right, so just remember that long term rehab is an opportunity to refine and develop. It's very rare that you're going to get to work with an athlete one on one where you're not going to have to compete with the stressors of their sport. And just remember that the same rules of training an injured athlete or that training a healthy athlete apply to training an injured athlete, but the base is lower and the price of error is higher. Okay, you can make mistakes with a healthy athlete. I, I've done it plenty. You can't make mistakes with an injured athlete, or you're talking about setting them up for failure and possibly re-injury. So the specific groin injury that I'll be talking to you guys about today and how I would go about it is just an adductor strain, as it is the most common. Generally damage to the adductor longus. Generally presents with pain running down the thigh up into the groin. And on average, in most scenarios, we're looking at 4 to 8 weeks in acute situations and as long as 6 months in chronic scenarios. So phase one, objectives and methods, primarily focusing on restoring their range of motion, motor control, and movement competency, identifying what is the actual diagnosis, planning and communication with everybody on the performance team. Contraindications during this time is any movement that will put the athlete into an excessive anterior pelvic tilt, transverse or frontal plane movement, split stance positions, deep hip flexion, and excessive abdominal bracing. Isolated rehab during this time is going to be pretty simple, right? It's lots of passive treatment. We'll implement EMS, BFR, some lymphatic massage, compression, modified conditioning for 2 to 3 exposures a week just to maintain a certain level of aerobic conditioning using steady state work or intervals. We'll do some low intensity isometrics for mechanotransduction effects. Now, what that is just really just extensive isometrics to create this mechanical trigger for cell to cell communication and effector cell response to mitigate some of the inhibitions that we see from injuries and prevent maybe some of the tissue shortening that we generally see. And the return to run in this phase is very simple. We're just trying to restore their walking gait. Okay, this is generally, especially in short term scenarios, a very short timeline here. Exit criteria is simple. We need an official diagnosis from the sports medicine team, subjective decrease in overall pain, tolerance to low intensity isometrics, looking at less than or equal to 3 out of 10 on the pain scale, and a normalized walking gait. Phase two, objectives and methods. This is where the athlete will spend the most time generally. Primary emphasis is to restore strength, tissue tolerance, and return to running. Severity of injury is going to dictate a lot about what we can do during this time. Some athletes will be able to start in more advanced stages. Some will have to regress. Uh, all rehab will be done less than 3 out of 10 on the pain scale. And if I'm working with athletes, which is all I work with now, I generally even try to sit a little bit more on the lower end of those numbers, just because one thing that we do know from research is that athletes have a considerably higher pain tolerance than their general population counterparts. And a lot of these pain scales are actually derived from general populations. So just be aware of that anytime you're working with an athlete. Generally, in these soft tissue lower extremity scenarios, I'm working with a 2 days on, 1 day off structure. Uh, Mondays and Thursdays being a little bit of our higher days, where we're performing our drills, our sprints, our intensive change of directions, and our isometrics. And then Tuesdays and Fridays being our drills, our tempo variations, and our dynamic contractions are a little bit more of our low intensity days, with Wednesdays and the weekend being off generally. Isolated rehab, so working on active mobility, strength training, working from extensive isos to intensive to dynamics. If the strain is more proximal, meaning it's higher up into the groin, we'll generally use BFR to flood the less vascular tissue. We use various hip flexion angles and adduction angles to make sure that we're targeting or avoiding any specific areas that may be exacerbating the pain. I think the most important thing from a loading aspect during this phase is just trying to identify what we can load and what the athlete can tolerate, and then loading it while the damaged tissue plays catch up. Right. So in terms of specific methods, I love extensive isometrics. Understand that the lower the intensity, the more frequent the exposure can be. So we can actually perform these generally every day during the rehab process, especially the less intense that they are. Understand that a lot of these injuries are caused, especially the ones that may be involving the tendon, are caused from excessive jerking. So make sure that you're starting light with these and gradually working into more of an intensive contraction as time goes on. We're generally looking at 4 to 8 sets, 15 to actually probably 60 seconds. 2 to 3 exposures a day, separated by 6 hours every day. And we do that because, one, that's what the research shows. We can get some connective tissue benefits. But two, we also get this tendon creep where the tissue will actually shorten during these contractions. And then after about 30 seconds, we'll actually see the tendon start to lengthen and fill in with greater amounts of connective tissue. Um, we've seen that from Keith Barr's work, which is really, really great. And I recommend you go look at. Once the athlete can tolerate extensive isometrics, we'll progress into more intensive isometrics. Uh, Generally, a Copenhagen progression, short levers, long levers, and the quasi isometrics, like you can see at the top there in the video. 4 to 6 sets done daily, 10 to 20 seconds at the time. Now we're starting to get after a little bit more intensity. Phase two, we're looking at dynamic contractions now. Once they can tolerate the isometrics, prioritizing eccentric contractions. Once they reach this point, the loading is intense enough to where they will need at least 1 day off in between loading. So we'll generally progress from open chain to closed chain, 6 to 10 reps performed every other day. Now the return to run process during phase two. We're not worried about necessarily preparing them for the demands of their sport right now in terms of a external loading standpoint. That was a mistake I think I made early on in my career of trying to rush to some of the GPS data. While it's important that we prepare the athletes for, obviously the demands of their sport, that's their job or our job. We want to understand that the context of a lot of that data is so specific to those actual sporting actions that right now we're just trying to restore their competency to perform some of those high intensity actions that we talked about earlier. So we'll start with a linear and multi-directional progression and can currently teach those, right, with some drills I'll show here later on. And just starting at a low intensity and gradually progressing them on. And then the same thing as the isolated rehab, we'll actually track their pain of each rep from 0 to 10, and then their perceived intensity from 0 to 100% on every single rep. Right, still staying under that 3 out of 10 on the pain threshold, never crossing more than 2 points without intervention within the same session. So if we start at a 1 and they get to a 3, I know I either need to regress the drill or I need to end the session for that day because the tissue has reached its capacity. Okay. Phase two. Okay, I'm not going to spend a lot of time on these, but these are just some of the movement prep drills that I'll use to reverse engineer some of those high intensity actions. And what I like about these is that it allows us to start at a very low intensity and low risk modality. Regardless of where the athlete is at kind of in this process, they should be able to start somewhere on this continuum and then just kind of gradually progress them based upon how they're responding to them. Right. And I think more than anything, what I like about them is it just allows me to, one, we get some really good specific loading of the tissue and dynamic movement. But two, it gives me a screen of how they move and what may be exacerbating their pain. Right. So phase two, like we said, linear progression. We'll start with our prep drills into resisted sprints, into unresisted sprints, into curvilinear sprints. Multi-directional progression would be prep drills into our 8-vector cuts, our change of direction drills, and then if we find it necessary, our agility drills broken up into score, defender, mirror, and dodge. Understand that the closer we get specifically with our return to run progression, the more and more that it needs to start looking like our actual sport. So here are some session examples. I just wanted to give you guys, just to give you guys an understanding of, you know, what these rehab sessions actually look like. So it's pretty similar on both days, right? So we'll start with day one, which would be a Monday. Remember, this is our higher intensity day where we're focusing on sprints, intensive decels, and our isometrics or quasi isometrics. So we'll start out the session, general mobility. We'll hit our tissue prep. Uh, we'll hit our mobility. Then we'll get into our movement prep drills or our locomotive drills, resisted sprints, unresisted sprints, close change of directions. And then for the isolated rehab, performing some quasi isometrics, hitting the adductor twice with some intensive and extensive isometrics, then hitting a hip dominant posterior chain movement, lateral hip or the lateral line, some oblique work, and then some tall kneeling chops. All right. And then day two, being our more low intensity dynamic contraction day, uh, same start to the training session, hitting our movement prep drills, doing our tempo variations, which may be a serpentine tempo, a linear tempo, or some sort of change of direction movement into a tempo. Um, Before progressing to our isolated rehab, where we'll hit we'll hit the adductor from a more dynamic standpoint with a rotational lunge and possibly a Copenhagen lift, hitting a knee dominant posterior chain, hitting the lateral hip again, and then some more dynamic core variations. So exit criteria for phase two, all right, is just a general tolerance to dynamic strength training, a tolerance to maximal linear sprinting and multi-directional movement, greater than or equal to 85% of general performance markers. Okay. And that's going to be a little bit different for everybody. And I'm not saying you're going to go out and, retest every single performance benchmark that you have, but I do think it's important to, have some sort of testing built into your training process so you can see just from a general output standpoint where the athlete is at in comparison to where they were at before. All right, from a range of motion standpoint, I want to see 100% from where their baseline was. So where they're at before the injury occurred from a hip flexed uh, external internal rotation. I want to see a symmetry from left and right side less than or equal to 15%. And then from a strength standpoint, I want to see them within that 80 to 120% of adduction to abduction ratio. And again, within 15% from left and right side. Phase three, okay, so now we're trying to reacclimate back into the sport. Ideally, using your position coaches to develop skill work, giving them specific constraints on what the athlete can and cannot do. Unfortunately, this is generally not a practical scenario for most, team environments. Oftentimes, we as the practitioner have to be the coach. So make sure that you understand what the demands of the sport are and reverse engineer them. Have a progressive loading scheme in place that can be scaled to shorter or longer periods. We want to make sure that this plan is documented and on paper, and that all stakeholders, including the sports medicine team, the rehab specialist, the performance coach, the athlete, the sport coaches, so on and so forth, have an understanding of what their role is within that process. Okay. From an isolated rehab standpoint, just focusing on end range strengthening and some high jerk and high rate strengthening. Return to run will involve, if we find necessary, some repeat sprints, long and short shuttles, and then some game sim and position specific scenarios. If, again, we find it necessary during this time. Quick one that I just want to hit on is just these high jerk strength movements that we use during this phase. And one thing that I've had a lot of success with are these oscillatory isometrics. Oftentimes, from a force standpoint, the strength comes back pretty quickly and is pretty easy to improve. What lacks late in these return to play processes are our ability to produce force at rapid rates. And it can be really hard to replicate high speed adduction and abduction without invoking pain out on the field. Um, and then lastly, where I honestly have the most success with these is just where athletes that haven't been cleared for run, but are cleared for or have progressed to, you know, being able to tolerate high intensity, high velocity loading. I find these are just a great way to bridge the gap. So generally performing 4 to 8 sets, 6 to 15 seconds, , no more than 2 to 3 times per week. So actually getting into the return to play process now and what that actually looks like. All right. So I follow a very, very linear progression. And just being the kind of general rule of thumb that you see a lot is just we never want to make more of a jump than 15%. Okay. So in shorter term scenarios, I'll maybe start an athlete out at 70%. But in long term scenarios, and most often, I'll generally start an athlete out at 15% of just total load of what that practice session might be for the first week, with the volume being broken up, or with the volume and intensity broken up 50-50. The next week, increasing 15% with more of a volume focus. The following week, again, increasing 15% with more of an intensity focus. And then week 4 is just being a full acclimation back into the team training environment. Okay. So we can scale that to shorter or longer, depending upon where the athlete is at and how long they have been out of the team and training environment, right? Remember that we don't want to rush an athlete back, but we also don't want to hold them out uh, and cause more detraining if they're ready to get back into the team training environment. Phase 3 exit criteria: clearance from all medical staff, a tolerance to practice and training demands, uh, greater than or equal to 90% of all general performance markers. Now, I would like to see them at that greater than or equal to 35 degrees of hip internal rotation, 40 degrees of external rotation, and a total arc of 75 degrees if structurally they can do it, right? Again, a lot of athletes just won't have the structure to be able to get into those ranges of motions, regardless of what you do. So just keep that in mind. And then again, wanting to see less than a 10% asymmetry from left and right side. From a strength standpoint, I want to see a 10% increase in, or within 10% asymmetry from left and right side, still within that 80 to 120% adduction to abduction ratios, an increase in adduction peak force, and then a maintenance of all previous benchmarks. Those are my references. And then this is where we would have questions. Here's my contact information. If you're watching this presentation, please reach out if you have any questions or you think I might be able to help you. I can be reached at that phone number there, the email. I'm honestly probably most active on social media at either one of those apps. So please, if you feel like I can help you, please don't hesitate to reach out. Thank you again to Fit for letting me present today. And yeah, that's it.